Good afternoon, everybody. We'll just wait for people to join us and then I'll officially say hello to everybody. You can leave your cameras on for a while if you like. I'll leave it up to you. No pressure, of course. I don't know, I've been on a few conference calls today from people all over the country and we've done really well. We've got beautiful weather in Leicestershire and I know they haven't so much up north, nor in Northern Ireland, another call I was on today. So we've got beautiful sunshine. So I think we might be just about, yeah, I'm going to get going because Rakesh has got other responsibilities at 5 o'clock. So welcome everybody. My name is Liz Darlison. I'm the Chief Executive at Mesothelioma UK and I'd like to offer you a really warm welcome to this, our 15th webinar. Many of you will know we started these during COVID, really just to keep our community together and to keep the conversation going, and they've worked so well. We've continued with them. We have one scheduled for the last Monday of every month, and we've already got the plan set out for this year. We'd like to get experts in the field to come and present and update us on latest findings, practices, and so on. So it's a real pleasure to welcome one of my own Leicester colleagues this afternoon, Dr. Rakesh Panchal. Rakesh read medicine at the University of Leicester and was awarded his degree with honours and ranked first in his year, which is a great achievement. The prestigious Faculty of Medicine Gold Award was presented to him in acknowledgement of his outstanding academic excellence, and he became a member of the Royal College of Physicians in 2006. He trained in respiratory medicine in the East Midlands, and in 2013 was appointed as a consultant respiratory physician with an interest in interventional pulmonology at the Glenfield Hospital in Leicester, which many of you know is where I am based for my clinical work. So we were just talking before and actually can't believe that is 9 years ago that you appointed to that position, Rakesh. He's a member of the Institute of Lung Health and is the lead clinician for the busy pleural diseases and interventional pulmonology tertiary services, for which he has received Clinical Excellence Awards. Alongside his clinical practice, he plays an active role in both undergraduate and postgraduate education and is a local college tutor for the Royal College of Physicians. He's co-founder of the East Midlands Thoracic Society, sits on the East Midlands Specialist Training Committee and runs practical training courses in pleural procedures. And I'd just like to say a big thank you, Rakesh, for joining us this afternoon. You're going to give us an update on local anaesthetic thoracoscopy. I just remind everybody to post your questions in the chat. I'll be happy to ask them for you at the end. And this is being recorded today, so it will be available on catch up. So thank you, Rakesh.
Thank you very much. So thank you, Liz, for that introduction, and thank you to Mesothelioma UK and the team for inviting me to deliver this talk. So in the next half an hour, 40 minutes, I'm going to go on a bit of a whistle-stop tour about what is a medical thoracoscopy. And I'm going to put that into the context of how a patient's journey begins when they're going to have a medical thoracoscopy. So I'm going to talk a little bit about the pleura. What is a pleural effusion? What causes pleural effusion, so fluid around the lung? And then what is a medical thoracoscopy? So as many of you will be aware on the calls, you've got two lungs and the pleura is the lining of the lung. So it's like cling film which envelopes the lung. So there's two layers of pleura, one which covers the lung and one which covers the inside of the ribs. So I always say to patients, your lungs are normally directly under the ribs, and in between the two, you can get fluid building up, which is called a pleural effusion. So there's two linings of your pleura, one on the surface of the lungs and one on the inside of the ribs, as you can see in this picture on the right. Interesting slide here. So a bit of information. So elephants don't have a pleural space. So they have two pleuras and a pleural space when they're being born, but by the time they're delivered, the pleural space is obliterated by connective tissue. So the pleura is not there. So they can't get collapsed lungs or fluid building up around their lungs because there is no space for it to build up. And one of the theories is that it's supposed to help them snorkel underwater and reduce sort of the effects of collapsed lung or fluid around the lung from their enormous bodies and the pressure on their lungs. So an interesting fact there. So we're obviously talking about asbestos and mesothelioma today in the context of medical thoracoscopy. So you'll already be aware, and this is an American slide where obviously you're exposed to asbestos fibers, and you inhale them or ingest them. And these fibers can lodge themselves in your tummy or in the lungs. And obviously, over time, the cells that it affects can mutate and become cancerous. And as you'll be aware, there is a significant lag period between being exposed to asbestos and developing a cancer of the lining of the lungs called mesothelioma, or a cancer of the lining of the tummy known as peritoneal mesothelioma. Again, some of you will be familiar with this, but I'm just going to mention that there's many different diseases that can happen because of asbestos. So you can have pleural plaques. This is thickening of the lining of the lung, the pleura, which happens over time and can become calcified. Pleural plaques are just a stamp in your passport to say you've been to asbestos land. They themselves are nothing to worry about. Asbestos can also cause pleural thickening. So it's the lining of the lungs becomes thickened. So instead of being like cling film, it's like rind on a piece of bacon or orange peel potentially. Asbestos can obviously cause cancer of the lining of the lungs, the pleura called mesothelioma. In the lungs itself, it can cause scarring and fibrosis of the lung, which is called asbestosis. And obviously, it can increase the risk of lung cancer as well. So let's start with the patient. So the X-ray on the left here is a normal X-ray. You've got the heart in the middle, the left lung here and the right lung. And here's the diaphragm, the muscle which separates the chest from the tummy. And on the X-ray on the right, you don't need a medical degree for this. You can see that it's not symmetrical. There's clearly an abnormality in the right side here. And this white area on the right side with a meniscus here suggests that there is fluid around this lung, what we would call a pleural effusion. So what are the causes of pleural effusion around or fluid around the lungs? This is a cartoon. When we see patients in our clinic, we say that fluid around the lung can be put into two categories based on the protein levels in the fluid. So if the protein levels are low, we call it a transudate. And that often happens due to people who may have heart problems, liver problems, kidney problems, low albumin, where there's pressure causing fluid to be leaked into the space around the lung. But these patients may also have swelling of their ankles. Fluid which has a high protein content, we call an exudate. And high protein content fluid happens because of infections such as pneumonia or TB, inflammatory conditions, but also cancer. So lung cancer or cancer which is spread to the lining of the lungs, or due to mesothelioma. So when you present with fluid around the lung, the first thing we would do, or pleural effusion, is do an ultrasound scan. And that allows us to see where the lung is. And in this picture here on the right, the black picture, you can see that this black area where my arrow is pointing is the fluid around the lung. So here's the lung, here's the chest wall, and this is the black area is the fluid in between the two. We often start with putting a needle in, and for those patients who have fluid around them, we start with a needle aspiration. So we draw off about 50 mils of fluid from around the lung. It's like a blood test. It stings a little bit of pain, but only takes a few minutes to draw off the fluid. And you get this you get variations in color. You can get this straw-colored fluid, you may get orange fluid, you may even get blood-stained fluid. And we send that fluid off for tests. So we want to know the protein levels, because that helps us put the fluid into two categories, one of two categories. We send it to the pathologist to see if there's any suspicious cells in it. And we also send it to the microbiologist to see if there's any infection. Now, on this study, they looked at how often does the fluid give us the answer of what sort of cancer might be going on. Now, when we take the fluid off the chest, if we're worried about, for example, an ovarian cancer or breast cancer or a hematological cancer, then for ovarian and breast cancer, the fluid often gives us the answer in more than 80% of cases. But if you're thinking about lymphoma or a cancer of the blood or hematology problems, or mesothelioma, then the fluid really doesn't give us the answer. So we'll always send the fluid off for tests, but if we're suspecting a cancer of the lining of the lungs due to asbestos exposure, such as mesothelioma, then the fluid will not give us an answer. And that's why we often need to proceed to a medical thoracoscopy to get a biopsy of the pleura. So when do we perform a medical thoracoscopy? So if the protein is high, if the pathologist can't give us an answer, and we suspect cancer because a CT scan has suggested something cancerous going on, and the cause remains unknown, then we proceed to a medical thoracoscopy. So what is a medical thoracoscopy? It's a procedure, and it involves internal examination of that pleural cavity, so that space in between the lung and the chest wall, where we can see that lining of the ribs and the lining of the lungs, the pleura. And Hans Christian Jacobius is the father of thoracoscopy. He was a Swedish physician at the Karolinska Institute, and you can see there was quite sort of primitive ways of looking into people's pleural cavity. So here, this patient's got fluid in their left lung, and he's created a space with a space where he can look under direct vision to see what's going on in the space around that patient's lung. So there are two ways we can do a thoracoscopy. So a thoracoscopy is a camera or telescope examination, remember, in between the ribs into the space around the lung. Surgeons can do it under general anesthetic, or physicians, so medical consultants such as myself, a respiratory doctor, can do it under local anesthetic. So there's two ways of doing it. And the difference is thoracic surgeons will do it under general anesthetic in an operating theatre, and I will do it under local anesthetic and sedation, so medication to make you sleepy but not put you completely to sleep. So, and essentially, in terms of getting a diagnosis of why the fluid is around your lung, both are equally effective. Similarly, the medical thoracoscopy that I do can be done using two different pieces of kit. You can put a flexible camera like a bronchoscope. So when you have an endoscopy into the lungs, there are similar cameras available which can be put in between the ribs into the space around the lung where the fluid is, and you can get a biopsy. Or we can use these more rigid instruments. But again, the yield is very similar. So it depends on the setup in the hospitals you're referred to, whether it may be a surgeon doing it, or whether it be a physician doing your procedure using a flexible camera or more rigid instrument. So it depends on the setup. So when might we not be able to do a medical thoracoscopy? So when we do a medical thoracoscopy, you're lying on your side. So you lie on your good side with the bad side where the fluid is up. So in this case, this patient would have a fluid on their right lung. And you do need to be able to lie on your side satisfactorily. That's the first thing. If your lung is stuck to the chest wall, or you've got a respiratory failure, so you're on high flow oxygen, you've got an uncontrollable cough, severe heart problems, or the pressure in between the heart and the lungs is high, or we can't consent you, then obviously we can't do the procedure. Relative contraindications are, if you're on blood thinning medications, then we can stop that safely in order to do the procedure. Obviously, if in those patients who are overweight, then you can imagine the space between the skin and getting into the space where the fluid is can be quite large or thick, then it can be logistically or practically difficult for us to do the procedure. Obviously, if you've had a heart attack within 4 to 6 weeks, we'll delay it. And obviously, if you've got severe immune problems, then there might be a reason we can't do it. So how does a patient end up having a thoracoscopy? So you may be seen in a clinic where people have fluid around their lung, or in a cancer clinic. The doctor will take a history, examine you. We'll have the X-ray showing the fluid. You may have had a CT scan, and someone is likely to have taken some fluid off your chest already for tests and done an ultrasound scan. If all of this is suggestive of a cancerous process like mesothelioma going on, the fluid hasn't given us the answer. As you know, the fluid isn't very good at giving us an answer. Then we will proceed to a thoracoscopy, maybe within the next week or two. You'll have some bloods done. We save some blood in case during the procedure there's a bleeding complication. We need to give you a transfusion. We'll consent you, give you advice on when to stop the blood thinning medication you're on. So if that's warfarin for an irregular heartbeat, we normally say stop it 5 days before. Clopidogrel, so if you've got heart problems or stents, then we would get advice, but suggest stopping that 7 days before. And you may be on one of these sorts of tablets called DOAC, so rivaroxaban, apixaban, dabigatran. These may be for irregular heartbeat, but also blood clots in the leg or lung, and then we might suggest stopping that for 2-3 days before. If there's a reason we can't stop your blood thinner so many days before, then we might give you heparin injections to cover you just until the day before the procedure. You may be consented in clinic or the day of the procedure, and we sort of normally consent you for the risks of the procedure are infection. So like any invasive procedure, there's a risk of infection of about 1%, bleeding 1% of death. of 1 in 250, and that's all comers right from 19-year-olds to 90-year-olds. So we do a whole range of age groups. On the day of the procedure, so this can often be done as a day case or with an overnight stay, we'd suggest you have nothing to eat or drink 6 hours before the procedure. Nothing to eat 6 hours before the procedure, and nothing to drink other than clear fluids such as water 2 or 3 hours prior. So in our setup, we do our procedures in the afternoon. On a Tuesday afternoon, our patients are allowed to have a light breakfast before 8 o'clock. Then they kneel by mouth from 8 o'clock and come to a ward and can have water until 2 or 3 hours before the procedure, which we normally do about 1 o'clock, 2 o'clock in the afternoon. We want to make sure your oxygen levels are stable, that you can lie down in the lateral decubitus position, so this is on your side. You'll have your observations done, blood pressure, pulse, and an ultrasound. An hour before the procedure, we normally give you a pre-medication, and that is liquid morphine. So that's just to relax you. We will normally put a little needle in your hand on the same side as the fluid is on. So if it's on the right side, you'll have a needle in the right hand. If it's the left side, you'll have a needle in your left hand. And that's to give you some fluids, because if you're not eating or drinking, we want to give you a drip of some fluids to rehydrate you. And then you'll be reviewed by the doctor or registrar before the procedure, who will review you, check your bloods, make sure you've been consented, and review your x-rays and ultrasound scan. Actually, in the endoscopy room, normally you'll have the doctor and registrar and 2 nurses, one who's the scrub nurse and one nurse who will stay with you and monitor you during the procedure. We will monitor an ECG, so a tracing of your heart, your oxygen levels, your blood pressure. And then we'll give you some sedatives. So remember, medical thoracoscopy is not done under general anesthetic, it's done under sedation. So we give you one of 2 medications here. One is a painkiller and one is a sedative. So I often say to patients, it's like having, what's your favorite tipple? And it's like having, I don't know, a gin and tonic or feeling a little bit woozy. So you're not completely asleep, but enough to hopefully not remember the procedure. So before the procedure, we'd always like to have a CT scan here. That's showing fluid around the lung. And obviously, again, an X-ray showing where the fluid is, and you've done an ultrasound. So I'm going to take you through the procedure. So this is our endoscopy suite where we do it. We have a stack like this, which has a monitor, so we can see the images what we're going to see when we're in the chest. And we'll set up our trolley with all the equipment we need for the procedure. As I said, we'll monitor your heart rate with an ECG, stickers on your chest, your blood pressure and your oxygen levels. We will do an ultrasound scan just before we do the procedure with you lying on your side. And you can see here, this black area is all the fluid around this person's chest. This is their diaphragm. This is the muscle which separates their chest from their abdomen or their tummy. And you can see here just on the diaphragm, there's a little shadow. So I know that there's something abnormal in this patient's chest, which hopefully I'll be able to see with my camera when we get inside the chest. And you cannot see the lung here because there's so much fluid that the lung is compressed. So we'll give you some local anesthetic in the area to numb the skin and the muscle. So remember, we're going to go into the chest. So we're going to have the skin, the muscles, and then the lining of the chest wall. And we give you local anesthetic just to numb that. And then we obviously give you the sedative, which is midazolam and fentanyl. So the midazolam and fentanyl is given through the drip, and the local anesthetic is given at the site. When you're given the local anesthetic, we make sure we're in the right space, so we might get some of that fluid coming back. And then we set up all our equipment. So here, this is our camera. So this is the thoracoscope, or the camera, which will go into the chest to give us a good look of the inside. We then, once the area is all numb, we make a cut of about 1 or 2 centimeters in between the ribs. And then using a forceps, we will open up the space in between the ribs, so the skin and the muscles to get into the space. And you should only feel a little sort of pressure here because it's all numb and you've been given lots of local anesthetic. You should just feel sort of a little bit of pushing, but no pain. Once we're into the space, we put a little cannula in, okay, a little metal device which has a hole in it, and then we'll suck all the fluid out. So what we do is we suck the fluid out slowly in 500 mils. So we drain off half a litre at a time, and then we check your blood pressure. Because remember, that fluid's been building up over weeks, days, and months. And we don't want to take it all off quickly. We want to take it off slowly, because if we take it off too quickly, sometimes the blood pressure can drop and the patient can cough and the lung can re-expand too quickly. Once we've taken all the fluid off and we can get no more coming back, here we've got the camera, and you can see the camera is going into that little metal cannula we've left in the chest. And as you can see here, we're about to just go in, and you can just see the lung beyond that. So when we're inside, so this is the inside of your the chest, okay? So here is the diaphragm. So remember, the diaphragm is the muscle which separates the chest from the tummy. Here is the lung, and this is the inside of the ribs, okay? And if you remember, on that ultrasound, we saw this little swelling on someone's diaphragm, and I can now see that directly with my camera and take a biopsy of that to send to the pathologist. You may also see other little deposits. So in this patient's chest, on the inside of the ribs, you can see that there's these little lumps here, which may be suggestive of something sinister going on. I'm not sure these videos are going to work, I'm afraid, but these were videos to show you inside of the chest, to show you the lung moving and the ribs. Okay, so then once we've drained the fluid off, we set up everything, and we will change our camera and put some forceps on to do the biopsy. So these are little bites that we need to take to send to the pathologist. So you can see here my forceps are opening, and we're able to biopsy this tumor, which I can see under direct vision, and we can take a sample to put in a pot to send to the pathologist. Similarly, more often than not, we also we want to strip the inside of the lining of the pleura off, and to send that off to the pathologist. Once we've taken the biopsies and all the fluid is gone, we pump some talcum powder in. So this is white powder, which is a number of different minerals. So it has magnesium, calcium, and the powder will cause the lung to stick to the chest wall, and we call that pleurodesis, to try and prevent the fluid from coming back. And that works in about 65 to 70% of cases. So you can see here, now we've taken the biopsies and we're pumping this talcum powder, and it's like an atomizer, like like women would use to put their perfume on, or pump powder. It's the same thing. We're just pumping powder into the chest, and you see this snowstorm appearance. So this powder, because the surfaces are wet inside, as the lung re-expands, powder will cause the lung to stick to the rib cage to prevent the fluid from coming back. So in thoracoscopy, you're draining the fluid, you're getting a biopsy to find out what's going on, and you're able to put talcum powder in to prevent the fluid coming back. So it's a one-stop shop. So here you can see the talcum powder. Once the procedure is finished, we leave a tube in the chest called a chest drain, and we attach that to a little bottle called a chest drain bottle to allow the lung to re-expand and let the air come out and any remaining fluid to come out. And this drain often stays in overnight. That's not going to work. So we stitch that in, and we put some dressings over it. And this tube, remember, about 10 centimeters of the tube will be in your chest. Apologies, I've got a little fly on my glasses. 10 centimeters of the tube is in the chest, and the other tube is coming out, and it's attached to a bottle. So we secure that in position, and then we'll do an X-ray. So you can see all that fluid that was here is gone. Here, this little, where my arrow is pointing, is the tube that's in the chest. And then, provided everything's fine, you may be able to go home the same day if your procedure is done in the morning. But if your procedure is done in the afternoon, you may stay in overnight. We often keep patients in overnight. And then Friday, the lung is re-expanded and no more fluid is coming out. The drain will come out. We'll put a stitch in, and you'll be able to go home. And you can see in this patient, we followed them up at a week. And in this case, the patient turned out to have an ovarian cancer. So when we're looking inside the chest, what do we see? We can see the blood vessels running inside under each rib. We can see the ribs. This is the space where the fluid would be. You can see the diaphragm and the lung. This is normal pleura. So the inside of the chest, you can see it's like cling film. You shouldn't see any abnormality. Now in the following slides, I'm going to show you, if you think about this as being the normal inside of your chest wall, you're going to see what can look abnormal in a moment. So sometimes if a fluid has been around the lung for a number of weeks or months, you may get these cobwebs occurring. So we call these septations, but it's like a cobweb inside the chest where all the fluid is become very congealed and very thickened. You might see little blebs on the lung. You may see a trapped lung. So what does a trapped lung mean? So remember I said the lungs have a lining on them called the pleura. And once you drain the fluid off, you'd expect the lung to re-expand and occupy the space where the fluid was. But sometimes the lining of the lung has got all this thickening on it, and it can look quite abnormal with cancer deposits, and that prevents the lung from re-expanding. So what we mean by a trapped lung is a lung which doesn't re-expand once the fluid has gone. You may see pleural plaque. So these are, as I said earlier, thickened areas of the lining of the lung, and then it becomes calcified. So this has calcium in it, and they're very thick and chalky. And these are just evidence of exposure to asbestos. So we often see these on X-rays and CT scan, but when we put the camera in under thoracoscopy, we can see these under direct vision. We would not biopsy these because they're very hard and can be painful. In mesothelioma, as you can see, I showed you earlier on what normal looks like, which was this. You can see in mesothelioma, it can be quite abnormal. So there's lots of redness here. So the lining of the lungs is all inflamed, and you can see these nodules or lumps and bumps on the inside surface, which indicate a cancerous process going on. And in this case, mesothelioma can look like a bunch of grapes because there's so many nodules affecting the lining, the inner lining. But mesothelioma can also look like this. So this is an adenocarcinoma, a type of lung cancer, but it can also be very similar. So you need to know the anatomy quite well in terms of where is the lung, where is the lung, where's the diaphragm, what's the inside of the ribs. So this is the lining, which should be like cling film. You can see it's all very thickened, very red, angry, and inflamed. And when you see this sort of deposit, it worries you about a cancerous process. Sometimes you don't have to have a cancer of the lining of the lung, so it might not be mesothelioma, it might not be lung cancer, but it might be a cancer which has spread to the lining of the lungs from elsewhere. So here you can see these different nodules. So in this patient, for example, they'd had a history of a mastectomy, a removal of the breast for breast cancer 5 years ago. Obviously, they built up fluid, and in this case, when we did biopsies, it came back as metastatic breast cancer, which had reoccurred. Sometimes the lung can be stuck to the chest wall. Depending on where you work, sometimes, as I said, you remember I said patients can have fluid around the lung because of infection, inflammation, or cancer. It can happen because of infections such as TB. So you see this cheese-like material sometimes with cloudy fluid, and that might make you think of infection. So we can send that off to the microbiologist as well. If you've had an infection for a long time, you can see again this cobweb type appearance occurring, which implies that the fluid has become very thickened and organized. So overall, medical thoracoscopy is a safe procedure. During the procedure, your oxygen levels can drop. That happens less than 2% of the time. After we've done the procedure, we normally expect the lung to re-expand, but some of the air might continue to leak or can leak into the space around the skin. That's less than 2%, and that's called surgical emphysema. Or sorry, surgical emphysema is less than 1%. You might get a persistent leak of air coming out. When we give you talcum powder, remember we're sticking the lung to the chest wall, and that creates an inflammatory reaction. Some patients will get a fever, okay, and that fever is just because the lung is sticking to the chest wall. There's about a 1 to 2% risk of developing an infection, and as I explained, the risk of dying is less than 1 in 250. And we do patients, right from their 90s down to 19-year-olds. So any real patient who's reasonably mobile and can lie on their side and is otherwise fit is able to have this procedure. As I explained, after the procedure, we'll do an X-ray. You will return to the ward and be given some painkillers, because of pain from the wound and where the drain is. We give heparin injections to patients in their tummy to prevent blood clots from happening. That's normal protocol in hospital. And the nurses will do their observations and checks on you to make sure blood pressure, heart rate, oxygen levels are fine. In some patients, the lung doesn't fully re-expand. So on the tube that's coming out your chest, we can put a little suction device, is like a bit of a reverse, like a very low grade vacuum cleaner, just to try and draw the air out and pull the lung up. Okay. As I say, some patients go home the same day. Most patients are in at least one day, maybe two. So we ask patients to bring an overnight bag. You'll be told how to look after the little bottle called the chest drain that you'll have with you. And once the fluid is gone, X-ray looks fine, the drain will be taken out and you'll have stitches applied, stitches and a dressing applied, and those stitches can come out a week later. Often when you've gone home, what happens is the biopsy was sent to the pathologist, and then we discuss your case at the multidisciplinary team meeting. So we have the X-ray specialists, the surgeons, the cancer specialists, specialist nurses, and we say, well, look, we'll review the CT scans, the X-rays, the biopsy, and say, well, what sort of cancer is this? If it's mesothelioma, we'll then decide whether we're going to send you for potential surgery, recruitment into trials, or oncology treatment. And we'll see you a week later to tell you the results and the plan. We'll probably repeat an X-ray at that time and remove your stitches once we tell you what the appropriate plan is. If the fluid has built up again, which can happen, or you've got a trapped lung, remember trapped lung is where the lung doesn't re-expand, so the fluid may build up again, then there are other things we can do. We can put a semi-permanent drain in called an indwelling pleural catheter. It's a semi-permanent drain. So this is a drain which is tunneled under the skin and stitched in to anchor it in position. And you take that drain home to drain the fluid off maybe once, twice, 3 times a week. Now, sometimes when we do a biopsy, in the majority of cases, we're suspecting mesothelioma. The pathologist will be able to tell us what it is mesothelioma. But sometimes the pathologist comes back and says, well, this looks like benign pleuritis, fibrinous pleuritis, or reactive pleuritis. These 3 terms mean the same thing. What does it mean? It means that there's just inflammatory tissue. So it's not normal, but it's not abnormal enough to call it cancer. Okay. This, when we get an answer of inflammatory tissue affecting the lining of the lungs, the pleura, we like to keep an eye on that. And it happens in about 30 to 40% of cases, so it's quite common. Now, if we're suspecting on the CT scan that this certainly looks like cancer, and it comes back, so it looks like mesothelioma, but the biopsy comes back as just inflammatory tissue, then we're often not happy. We think, well, no, you know, this biopsy is not correct. And then we might send you for a surgical biopsy to take some more biopsies from different sites around the chest wall. But if you have had a history of exposure to asbestos and the CT scan doesn't show any obvious features and the biopsy just shows inflammatory tissue, then we will normally keep an eye on you for, or it's normally advised that we should keep an eye on you for 2 years. So we see patients every 6 months for 2 years. And that's because, according to the literature, about 12 to 15% of patients will go on to develop a cancer over the following 2 years. And based on our own research in Leicester, we found that in those patients who had inflammatory tissue with a history of exposure to asbestos, so they had a diagnosis of this benign or reactive or fibrinous pleuritis, over 2 years, 50% of those where it progressed ended up being mesothelioma. So it's important to keep an eye on these patients. And I'd say after 2 years, if nothing's developed, then it's unlikely to occur, in which case it really is just inflammatory tissue. So Mesothelioma UK has some excellent resources and some patient information leaflets which are available on their website about what is pleural effusion, what is a medical or local anaesthetic thoracoscopy, and what is an indwelling pleural catheter, and I'll direct you to those resources. I'd also like to direct you to an excellent website called mypleuraleffusionjourney.com. So this has been put together by colleagues across the country, and it's a free website, and it has excellent videos on what is fluid around the lung, what is the pleurodesis, so the talcum powder we put in, what is a trapped lung. It tells you what is a medical thoracoscopy, and has lots and lots of resources and videos to watch about people with fluid around the lung and their journey. That's it from me. So thank you for listening. And if you've got any questions, I'm happy to take them.
Lovely. Thank you so much, Rakesh. It makes me realise how lucky we are in Leicester to have such a comprehensive pleural service. So there's been some really nice comments coming in. Thank you. Very interesting, descriptive question. This is from Kate, I think. Yes, from Kate. Hi, Rakesh. We had this lady this morning who was due an MT, but the spaces between her ribs, medical thoracoscopy, but the space between her ribs was too small for the instrument to pass. I hadn't come across this before. She's now waiting for a VATS.
Okay, so yeah, so obviously medical thoracoscopy, as I explained to you, you can do it under the thoracic surgeons can do it under GA, or we can do it under sedation and local anaesthetic, which is what a medical thoracoscopy is. But remember, the patient is going to be awake during a medical thoracoscopy. So if the ribs are very crowded, which you can get with some elderly patients sometimes, particularly those patients who may have slight curvature of their spine, then the ribs can become crowded. So you're right, it can be very hard to get the instruments in which case, obviously, just under some sedation and even local anaesthetic, it can be quite sore. So that patient might need a surgical procedure where, obviously, under general anaesthetic, they are knocked out, and that means you can sort of manipulate the space a bit more than what we would be able to do. But obviously, that has risk of general anaesthetic and, again, an overnight stay. But we have the same issue sometimes with patients who not only have crowded ribs, but patients sometimes who are overweight, where again there's a technical challenge with the actual instruments getting in as well. So those patients might need a surgical thoracoscopy as well. It's fairly rare. There's a question there saying, do you send patients home with
on morphine?
Oromorph. So sometimes, yeah, often we get away with cocodamol, but we will send patients home with Oromorph, particularly if they've had a lot of pain even before the prior to the procedure. But yeah, we do send home patients with Oromorph. It says 9 times out of 10 we place an IPC. Yeah, interesting. So so an indwelling pleural catheter is a semi-permanent drain. There's a big study going on. There's a study which we're about to start, or it's already recruiting, called the TACTIC trial. So this is putting talcum powder in versus putting a semi-permanent drain in and sending the patient home the same day. We don't know which one is more effective. Some centres will put a semi-permanent drain in an IPC and send them home the same day. But it's about the cost effectiveness of that, because how often are you going to drain that patient? Then when are you going to remove the indwelling pleural catheter? I get it. If you put one in right from the beginning, then the patient may never need another procedure again. But we tend to reserve it for patients who we think have a trapped lung at thoracoscopy, because it avoids them coming back for another procedure, but we don't routinely place it. But that depends on your setup. I know that one of the hospitals down the road from us, and Cambridge, also put an indwelling pleural catheter in all patients following a thoracoscopy. But as I say, there's a study called the TACTIC trial by Bristol, which is going to be looking at standard practice versus putting an IPC in everybody. So I think the jury's out still. We need to see the cost effectiveness of it.
I've got a couple of other questions actually, Rakesh. One is, do you get a feel for how much of the country now does not have access to local anaesthetic thoracoscopy? I mean, I've worked in mesothelioma services long enough to remember many years where it just wasn't a procedure that was available, wasn't even thought of. It was always a surgical procedure with a general anaesthetic. And it really did have a huge impact on our histological confirmation rate for mesothelioma. And for all sorts of other reasons, it's, a huge, it gives a huge boost to our diagnostic services. So do you get a feel for how much of the country doesn't have access to local anaesthetic?
So there is, I need to look it up, but there is a nice survey done by Denisha Fonseca in Sheffield, who used to work with Nick Maskell, looking at local anaesthetic thoracoscopy services across the country. And over the last 10 years, it's certainly gone up much more. I don't have the figures, but it's quite widespread. One of the main pockets, funnily and surprisingly, is London. So the London areas really don't have access to medical thoracoscopy, because I think it's held on to by the thoracic surgeons. So most patients have to be referred for a VATS procedure. So we had a colleague with us who's now working in Southend, and they say they want to set up a medical thoracoscopy service, because at the moment in that area, they're having to send patients to London for a VATS, and the wait time is 3 weeks. So central London hospitals, nobody does medical thoracoscopy at the moment. And I think some of the south east, it's limited as well. But I know they're trying to improve it in some of the district hospitals, particularly sort of Southend, I think Basildon, Broomfield, that area. But yeah, I'm not sure why Central London doesn't do it. The only place in Central London that I know that does it is St Thomas's, I think, where Leisure Ahmed was, but otherwise not. That's one of the main areas I know.
It's interesting, isn't it, that it may be because they have better access to thoracic surgery that it lessened the need. And anyway, it depends which way you look at it.
Yeah, I think it's multiple reasons, but I know there is a wait, but that's the one area which I'm aware of that medical thoracoscopy is not widely available.
I may have missed this as well. You may have said this, but first drainage, and subsequent drainage, what's the maximum amount of fluid you would drain off of an individual?
At thoracoscopy?
Yeah.
Yeah, so as I said, the fluid has been building up over weeks, days and months, and some patients can have 3-4 litres, even more in it, in the chest, and you'd be surprised how well people tolerate it. I remember one guy, I think was 6'3", and no, 6'4", and he's probably taller than that. He's very tall, and when we went in, I think we drained 7 litres of his chest. I just don't know how he lived with that much on his chest, but the reason is the same. When you have a chest drain inserted on the ward, you should not drain more than 1.5 litres to 2 litres in a day. And that's because if you take too much fluid off quickly, you can get fluid shifts and the lung re-expands very quickly, and patients stop coughing, or they get very acutely breathless. So I often know, I say 1.5 to 2 litres, but that depends on the size of the patient in front of you. So my main thing is if a patient starts feeling a bit breathless or starts coughing, then you need to stop the drainage. Now, at thoracoscopy, we need to remove all of it. So what we do is we remove 500 mils, we take the aspiration catheter out, let some air in, and recheck the patient's blood pressure and wait half a minute. So we do it in 500 mil aliquots, and as long as we do it in 500 mil aliquots, we're able to remove all the fluid over 5 minutes or so. But what we shouldn't do is just take it all off in one go. And it's very tempting to do that, and that's because the lung re-expands very quickly, and there's what we call a ventilation perfusion mismatch. So the lung re-expands quickly, but it can't cope, and the patients will drop their blood pressure, become very breathless as well, and start coughing. But yeah, we've never had a problem where we can't remove all the fluid.
Okay, lovely. Thank you for that. And I guess the thing is monitoring the blood pressure as well, like you say. And also post-COVID, how was the service affected just quickly during COVID, and have you recovered from that? I'm just wondering, there may be some parts of the country that are still struggling because of access or whatever reasons.
So we carried on our medical thoracoscopy service during COVID. If your cytology was positive then obviously if your cytology was positive, then we definitely didn't do medical thoracoscopy. So let's say even if you're young and you had breast cancer and your cytology come out positive, and there was a need for more, unless there was a real need for more tissue, we wouldn't do the thoracoscopy. As you know, we work in an era where tissue is the issue now, and people want more tissue to do special molecular tests, etc., to try and find out what's going on. But if we suspected mesothelioma or lung cancer and we didn't have an answer, then we carried on. So and the BTS plural specialist advisory group did say that in patients where the pretest probability for cancer is high, that thoracoscopy procedures should carry on. But I would add, we swab all our patients before we do thoracoscopy. I think the previous rule was to wait for 4 to 6 weeks after you've had a positive test to before doing a procedure, whether that be a bronchoscopy or an EBUS or even a thoracoscopy. But I've changed that now. If you're positive, then provided you recovered 7 to 10 days later, then I'm happy to proceed, because we can't really wait. The one thing we were doing more during COVID, as we sort of briefly spoke about earlier, was putting more indwelling pleural catheters in, because people with pleural effusions, even if it was due to mesothelioma, didn't want to come into hospital to have a chest drain and be sitting in a ward for 5-6 days at the risk of catching COVID. More people were saying, can you put a semi-permanent drain in, and I'd like to go home the same day, which is perfectly reasonable to me. So, and we've carried on that practice. More patients having indwelling catheters now first line. But thoracoscopy-wise, I think if it's needed, you need to get on with it, really.
Sorry about that. My phone started to ring just as we were talking then.
That's all right.
Lovely. Don't think there are any more questions in the chat. I don't think so. Thank you so much, Rakesh. Really enjoyed that. And I think that we really should invite you back to do the indwelling pleural catheter talk on another time, if that's okay. And I just want to say, I love the logo as well. Have you got a good artist in the team as well?
So this is a logo. So we had our 10-year anniversary last year, and he's one of the A&E consultants who likes doing sort of medical art. So I tasked him with putting something together for our 10-year anniversary, and he came up with that, which I thought was very,
very good. Yeah, very impressive.
So.
Well, thank you very much, and we'll look forward to welcoming you back. It'll probably be early next year, but to talk about indwelling fluid catheters. And just before people leave us, I just wanted to remind everybody that our next webinar will be on the 25th of April. And we have got Emanuela Felibosco talking about expressed genomes in mesothelioma. The team have also asked me to remind everybody that we have our expert witness training events this Thursday. It's an insight into expert witness training, and it's before we start our course in expert witness training. That's this Thursday, 6 o'clock. There's still places available. And from a fundraising perspective, our next fundraising initiative that we'd like everyone to get involved with is Muffins for Meso, and it's a one-day event on the 19th of May. And if you'd like any information about that, it's all on our website, or you can give us a call because we have got some nice packs for Muffins for Meso if you want to do some fundraising in your teams and with friends and family. So thank you very much, everybody. I hope you'll get some sunshine like we have got here in Leicester, and stay safe. Bye. Thank you, everybody. Thank you, Rakesh.
Thank you for having me. Bye.
Bye-bye.